for Hats Off for Health Chats. I'm really excited that you're all here tonight. We had a great evening last night with the men, albeit it was quite a lot smaller than what we have this evening, which is not surprising, but they had a really, really great night, some fantastic speakers, a lot of chat and a lot of great feedback. And I think I've also heard more feedback from a few partners that the chats continued, which is really great to hear, and one of the reasons why I thought these events were going to be really important. Looking around the room, I probably know most of your faces, but for those of you that don't know me, my name's Alice Bennett. I'm a gastroenterologist based here in the Mid-North. I'm also a local. I grew up in the area and have returned, married a farmer, and we live out east of Bullaroo with our 3 boys. I'm the founder of Hats Off for Health Chats, which is a side project of my original idea, Good Gracious Gut. I'm really passionate about rural health. I'm a local, I'm a rural person myself, and I really feel strongly that we should have equitable access to healthcare. Obviously, distance is a little bit against us. I mean, not as bad as some of the other regions in South Australia, and I think distance is different now compared to what it used to be 20, 30 years ago. We travel a lot more, and some of those barriers of distance have been overcome with technology and different ways that the differences or the disadvantages have been looked at. But I still think some exist. But when it comes to health information and preventative healthcare, I don't think that it should exist at all in this day and age with our technology. I think that we as rural people should have access to the highest quality of information, and we need to be breaking down the barriers of talking about topics that might not be the most pleasant things to talk about, but can be extremely important. So that's where my idea came from for Hats Off for Health Chats. This is the first location of 3 events for this year, and I've decided to split them up into men and women's, and I certainly don't want to be political in this day and age, splitting them up, but I really do think that it is important, and I think last night did show that it worked really well with the men. I think there were quite a few questions and comments that were asked, and a discussion that was had that probably wouldn't have occurred if partners or women were there, and vice versa. I think we'll have a lot of great discussions tonight that may or may not have occurred with men in the room. So I'm really excited. We've got some amazing speakers, which I'll introduce to you shortly. I did have a couple of thank yous and acknowledgements to make before we get started. So to AgriFutures, they provided a Rural Women's Acceleration Grant to me to get this project up and running. It provides funding for the development of the idea and for mentorship. I'm still looking for some more funding to get the projects up and going on the ground level. That should be coming soon. Meredy Gross Photography, she's obviously videoing these sessions for us last night tonight to provide sponsorship. So if you would like to look at the men's topics that were on last night, they should be uploaded shortly, or if you'd like to watch these again, you will be able to, or if people have missed out, they can have access to them. Free access to information is the main aim of the game, and the more people that see it and talk about it, I'll be a very happy lady. Other people I'd like to thank Dale and Jaffa Brothers Brewery. Obviously it's a fantastic facility that we have here in Melrose, and we've picked a hot weekend unfortunately, but it is a few degrees cooler down here. But Dale has been so fantastic to work with, really supportive of the idea, and provided sponsorship for the event to use this facility. And as I said, it's been really great to work with. Kerry from Experience Melrose has provided this beautiful spread of food, and she does a really good job, and thank her very much for that. And I'm sure there's a few more thank yous. And Gastroenterology Society of Australia have supported me with my idea, and they've been excellent. So, before I introduce the first speaker, the outline of the program, we've got 5 speakers tonight. I can vouch for 4 excellent speakers. I'm not sure about myself, but you have to put up with me now that you're here. We'll probably do 3 speakers, probably 5 minutes in between, where people can go and get a drink. Please feel free, if your buzzer goes off, to get food if you haven't got it already. Obviously go up and get that. So 5 minutes in between, we'll do probably questions mainly at the end of each speaker. But if you've got some burning questions, we had some great comments last night, which was fantastic. Please put up your hand, yell out. I don't think we need to circulate a microphone if everyone can speak up. But then we'll have probably a 15 or 20 minute break and then have the final two speakers of the night. So, first up, still alive. My phone. First up we have Nigel. Nigel did a fantastic talk last night. I'm really excited that he's come here to speak to you all again. So Nigel Young is a local, works and lives in Port Pirie with his beautiful wife Madeline. And Nigel, and I said this last night, I can't remember where we first met, but I've seen both Nigel and Maddie a few times in Melrose. They are keen campers and often visit the area, so definitely locals. But Nigel was born and raised in Wandeera on a farm, and he's the youngest of three. He's an accomplished physiotherapist of 11 years, working in both the public system initially and now private. He's the owner and director of Thrive Health Centre, which opened 5 years ago. And this is a multidisciplinary centre providing allied health services across 9 disciplines in the mid-north, York and far north regions. I'd like to give a really warm welcome to Nigel. He's a fantastic speaker, extremely knowledgeable, and I'm sure you'll enjoy his talk.
Okay, well, I suppose first things first, hats off to Alice for getting this together. It's one thing to donate a few dollars, it's another thing to spend the amount of time and go through the amount of effort that Alice has to put this together. And if we have a few people from each session make a positive choice that leads to a bit more quality of life or length of life, then it's all worth it. So well done, Alice. So yeah, as Alice said, I'm from Wandeera, off the farm there, and went to Adelaide for 10 years and came back and spent a couple of years with a few members here at the SA Health Service in Port Pirie, and then went out private and been doing that for a while now. So I'm going to talk to you about joint health and injury. Very broad topic, okay? So it's going to be something, no, that's okay. But that just means that it's going to mean something different for each person. And for example, instead of honing in on ACL injuries or arthritis, we're doing a bit more of a broad chat about it. And of course, feel free to sync it up with any questions along the way. Okay, so what the basics about joints. This isn't designed to be death by PowerPoint. Okay, we'll try and make it fairly interactive. Basically, there's 3 different types of joints. There's the fused type joints, the other ones like, for example, your cranial joints fused early on in life. They allow very little movement. Then you've got your cartilaginous joints. That's like, for example, the joints around your sternum or between your vertebrae and your back, or between your pelvis at the front here that allow a small amount of movement. And then you've got your freely mobile joints, which is the ones we're going to focus on tonight, your synovial joints, and they're the most plentiful throughout the body. And they generally contain, at the very least, the top 3, but a fair scattering of the others as well. So the synovial cavity is the gap between the bones, and it would stand to reason that when you're standing up you would feel as though all your joints are compressed down. But because there is pressure within the joint, quite often there is still some space maintained between the joint. The joint capsule is kind of like the Woolies bag that surrounds the joint. It keeps all the fluid in, and there's kind of 2 aspects to it. There's the innermost layer, which actually releases this beautiful milky fluid into the joint as a lubricant. And then there's the outermost layer, which will actually, let me jump onto that, and we'll use that as a bit of an example. So we've got, over on the left here is a very basic synovial joint. So you can see that the dark orange is the innermost layer, and that releases fluid into the joint to keep things nice and slippery and lubricated. But it also has another role. And there's little things in that, there's little factors in that synovial fluid that clean up the joint for you as well, okay? And there's also nutrition in that, okay? So if we're not moving these joints to splash that fluid around the inside of our knee, there's more chance that your cartilage and the other structures within your joint aren't getting the supply of nutrients that they require. Then you'll see the blue arch, or hopefully you all can. That's the articular cartilage, and that gets the most airtime. We all know about arthritis and the damages to those areas there. That's like a slippery surface that helps the joints move without too much friction. Then you'll see some other things, and I'm only going to really touch on this quickly. You'll see things like ligaments. That's your ACL and your PCL. That's inside your knee there. I've got a model here. You'll see things such as this blue thing in between, just there. That's your meniscus, where it's a cartilage pad, and that acts to shock absorb, and we have them in a range of our joints throughout our body. They also, other than being a shock absorber, for example, in the knee, this one's a bit like an egg cup as well. You can see that the bone's quite rounded on the bottom, and that stops the joint, or the top bone, from sliding around on the other bone as well. You'll also see things like the green thing in the picture there. They are bursa, okay? And bursa sits between tendons and bones to reduce friction, okay? And the yellow stuff there, that's fatty tissue, and that's like protection around the joint from trauma, okay? And then of course you've got the bone itself. Now, does anyone know what joint we're looking at here? What's the one on this side? Shoulder, and on this side? Okay, so they're probably two examples of the most mobile but least stable joint, and one of the most stable, although it still allows a little bit of movement, but a lot less mobile joint. So that just explains what happens in a lot of joints. You have a trade-off between mobility and stability. Okay, so the joints that generally allow more movement are going to be at more risk of injury. Okay. And you can see in the shoulder there, the ball is almost rolling around on a pretty flat plate there, so you're relying on a lot of things for stability there. So what can go wrong? Well, things can go wrong with all of those. I'm just going to very quickly go through this, and we'll get into some more interesting stuff then. So articular cartilage, obviously, arthritis is the one that we hear about the most. There are hundreds of different types of arthritis. I couldn't even begin to touch on them, but the ones that you'll know most commonly are the ones that are caused from friction or small micro trauma over time, okay, which is where the cartilage surface becomes a little bit rougher. And then there's the kind where the body decides to attack itself, so that the autoimmune type, where, for example, your rheumatic type arthritis is, arthritides, I'm not sure what the plural is there, that might start attacking that tissue. Okay? We've then got fractures. There's lots of different types of fractures, but in general, your prognosis is a lot better if the fracture doesn't include the articular cartilage, the smooth surface. Okay, so if you get a fracture through that, it is hard to maintain that nice smooth surface of the joint. Ligament and tendon tears. Does anyone know the difference between a ligament and a tendon? Anyone brave enough to say in front of this big group? Probably not. A ligament attaches bone to bone. Okay, so that's, for example, your lateral ligaments either side your knee, or the cruciates within it, which you would have. I keep using the knee because everybody tends to injure that at some stage throughout their life. And a tendon is attaching muscle to bone. Okay, so for example, your hamstring tendons coming down and attaching in behind your knee, or your quads coming down, turning into your patella tendon and attaching in through the front of your shin. And with regards to those, there's generally 3 grades. First grade, you're looking at sort of a 1 to 3 or 4 week injury, mild loss of function, small tear. Grade 2 is a fairly substantial tear of the tendon, very significant loss of function, and you're looking at a 4 to 12 week injury, and then a grade 3 is completely going through that tendon. And they can heal without surgery, we know that now, but sometimes when you go completely through a tendon, you will need surgical input. Infection, look, there are some infective types of arthritis, but generally the main way that you get infection in a joint is if you go through the capsule, and largely that's only after surgery. Okay? And that's why it's very important after surgery that you do the appropriate follow-up to avoid that. The cartilage disc or meniscal tears, again using the knee as an example, you would have heard of tags coming off the meniscus, or bucket handle tears where they split down the middle. Really poor blood flow to the meniscus, so they heal really quite poorly. But what we do know is that it's worthwhile trying a conservative approach first. I'll go through that in a minute. Otherwise, they can, of course, be clipped or sewn up. Tendinopathies is where the tendons get a bit grumpy when we're not looking after the muscles like we should, when we jump too quickly into activity. Again, we'll go into that in a minute. And bursitis, which is where those little fluid-filled sacs get a bit grumpy because we put a bit too much pressure through them. Okay. All right. So what can we actually do about this? There's the essentials. I'm going to go through each one of these really quickly. So the physical activity guidelines. Okay. So this changes all the time. Okay. This is the World Health Organization version. So basically, it used to just be 30 minutes, 5 days a week, and then they've slowly updated it over time. I guess what I'm trying to say is that if we can, at the very least, match our physical activity levels to what they're asking us to do, you're going to be much less likely to get joint injuries because your body will be used to movement. So now for adults, we're looking at 150 to 300 minutes worth of exercise per week, not per day, per week. With 2 or 3 days of that being having a strength-based component to it. Alright, so weight loss. Nobody really wants to talk about this, but it is really important for joints. So as you can see from that one stat, for each kilo that we lose 4 kilos of force through that joint. And that's particular, this stat is for the knee, but you would imagine that it's fairly similar for the ankle and the hip at the very least, and for the spine. So you don't actually need to lose a lot of weight to have a big impact, okay? And there's been heaps of research. I thought I wondered that Amy Trengo might be here tonight, the dietitian of the region, and she speaks more so about avoiding setting goals for losing 10 kilos, for example, but more so setting goals around changing lifestyle. So it might be dropping off the iced coffee on the way to work. That's probably more pertinent for the blokes last night. Or it might be smaller portion sizes, but focus on those things and the end result will be weight loss, okay, rather than disappointing yourself each time you step on the scales and giving up. Okay, now this one caused a few murmurs last night. You may not be able to see all of this. I'll go through it with you. There's a lot of information there, but on the left side, the blue diagram shows basically what we used to know as being how we deal with acute injuries, which is the ICE or the RICE method, which was created way back in 1978 by this guy called Gabe Merkin. He's still alive, and that's pertinent because I'll tell you something about him in a minute. But basically it was the rest, ice, compress, elevate. Okay? Then that got updated to PRICE with protect at the front, so you want to protect the joint as well. And then in 2012 it became police, okay, because the OL being optimal loading as well, so in other words, removing the R from RICE for rest and get back into activity. Then in 2014, RICE was retracted, and the main reason they retracted it was for the RI bit. So R being rest, we know that there's not a lot of evidence for rest now, which we'll see in the new acronym, which is awful. But it is very informative as to what the whole pathway should look like, not just the first 72 hours after an injury. And you'll also notice that the I's gone missing. Okay, so a lot of people ICE, largely there's not a lot of evidence for it now, which is quite a big surprise. So, for example, the thought process is, and the evidence so far is that when you cool something down, it stops a normal bodily process, which is actually required to heal. And if you think about this hundreds of years ago, where they wouldn't have had access to ice, the body would have adjusted over time to deal with the surroundings that they were in at that time and optimised how the body worked based on the fact that there wasn't ice, okay? And when you cool something down, it causes vasoconstriction, so all of the arteries tighten up, not allowing blood flow there. But what actually happens is if you do that for long enough, you're risking more tissue damage, and the body actually has a rebound response and opens up all of those arteries. Okay, so that's one of the methods. The other method is that unless you keep ice on for a decent amount of time, it doesn't get to the depth that you need it to anyway. So now in 2019, we've got a new acronym, Peace and Love, which we might need to share with the Russians. But Peace and Love, it shares a lot of the stuff that has been in the previous ones. But if you understand this, you'll be able to deal with any sort of acute injury. Basically, we want to protect initially. Okay, that may mean completely unloading the joint or doing less than what you were previously. Elevation, there's actually not a lot of evidence for elevation now either, but it's not going to do any harm to do it. Avoiding anti-inflammatory medication. I was a shocker for that when I was playing sport. I'd pop an anti-inflammatory thinking that it would slow down the process, remove part of the process, and in fact it does do that, but it's a process that the body requires. Compression, so that is, the main aim of that is, well, one, comfort for the individual going through the injury, but two, to limit the swelling as well. And that probably has more impact than what ice does from the research. And education. So we know that if you can get education early about what you're actually dealing with, look, if you're dealing with the ankle sprain that you've had 10 times before, you're not going to need it. But if you're dealing with a puffed up knee that is new to you, well, it's probably handy to get some advice early on so that we can set a decent program in place for you and reduce that threat level of the injury and get you back on doing whatever you would like to do sooner. So Peace handles the acute stage. Okay, so we're talking 2 to 5 days after the injury. Love is beyond that. Okay, eternal love. So L is for load. We need to start getting load back into the joint. In fact, after a lot of orthopaedic surgeries, next morning you're out of bed. Okay, they want you moving. We know that if you don't move, there was a study done recently, they mobilised a knee, 48% of strength over 3 weeks was lost from mobilising that knee. Thankfully you can gain it back reasonably quickly, but you do lose strength quite quickly, and we know that it's a 3-to-1 ratio as to how quickly you can lose it versus how quickly to gain it. Okay, so you're better off keeping it once you've got it. Alright, so once you've built that up, we want to get you moving as quickly as possible so that all the structures around the joint can do what they need to do. Optimism, this is a relatively recent one, it's very fluffy, but optimism, we know now that the brain controls your pain response, and pain is an input. So if I pricked you in the thigh, what would happen is a little bit of nociceptive input would get sent up to your brain, and then depending on the experiences that you've gone through in life, you may or may not get a pain response. And so if you learn about your injury and how to manage that injury early on, we can reduce that threat level and actually reduce the amount of pain that you feel in the believe it or not. Vascularisation, fancy word for get moving, and that is vascularisation might be, for example, if you've done a hamstring injury in footy, getting on the bike. Okay, and slowly start getting blood pumping around to revascularise, getting new fluid into the area, removing the old stuff. And then E is exercise, which is grading you back into exercise. A lot of people ask, well, how do you know what to do? Pain is a pretty good guide. So, for example, if you can, 3 days after your ankle injury, start walking around on it, please do, okay, to start getting things moving again. Again, thinking about those people from hundreds of years ago, they would have had to, okay? And this is little Merkin's thing down the bottom. Basically, he created it back in 1978, and he now says that it appears that both ice and complete rest may in fact delay healing instead of helping. So, we come around. Now, surgery versus conservative management. I was reading some studies the other day, and about 33% of people going through to orthopaedic surgeons have actually tried conservative treatment first. So that means 60-odd% are going straight in to have their knee lopped off and replaced, or having a surgery without first having tried to do it conservatively. And there's probably 2 things to that. One is that we need all of our medical professionals to understand this evidence, but 2, we need to understand this evidence so that we know that there possibly are other options as well. This was an interesting one. This was meniscal tear, that little cartilage, this study here, and there's a cartilage, I can't start again. The knee it was a 12-week intervention for conservative treatment versus having the surgical treatment. The results were pretty well exactly the same, but you had less chance of infection and whatnot if you didn't go through the surgical route. So it's not saying that some people won't need surgery, it's saying that there probably are other options to try first. Dynamic stretching versus static stretching, busting all the myths tonight. Static stretching before sport or before movement, almost no evidence for that now. Okay, so by static stretches that means these ones. Okay, the ones where you're not introducing any warmth to the muscle group. Next to no evidence for it. So if you're before netball and it's 3 degrees out there on the court and you're doing static stretches, there is actually some evidence that you're causing micro trauma to the muscle before you go out and play sport. So you are better off doing dynamic stretching, which is basically practicing the movements that you're going to be doing in sport or in your run or before gardening or before work, so that your body is used to those stresses when it comes up against them in sport. Static stretching, there's a bit of evidence for it either during or after match play to try and, for example, if you've overworked your calves, it's not a bad idea to give them a stretch after the game so that they return back to their normal length again. But not a lot of evidence for static stretching otherwise. Taping or bracing. A lot of people come to us that have had a sore knee or a grumpy knee for many years and they want to throw a brace on it. Just know that it's a double-edged sword. As soon as you stick a brace on something, you are doing the work of the muscles and the ligaments and the tendons for it, and therefore you're actually weakening the knee over time or whatever joint that we're working with. So you should it should be a last-ditch effort if you're going to wear a brace at all times. The other thing that taping and a brace is good for is weaning you back into activity. Let's say you've had a surgery or you've had an injury, it's nice to wear that when you're getting back into that activity again and slowly weaning off it. Okay? Please ask any questions as we go. Now you're not going to read the data here because the people in the front row might see it. I included this here and I use it all the time in the clinic. It's from Return to Work SA, which is obviously our insuring body for workers. And this is spinal imaging of 1,100 people that have no symptoms of back pain at all. Okay, so they have no back pain. But what you'll know, I'm 35 and 52% of people in their 30s will have disc degeneration. 40% of us will have a disc bulge, but you may not actually get symptoms from that. Okay, so it is possible. Degeneration is normal over time, and that it is possible to live with these things without pain. In fact, once you start getting over the age of 50 or 60, it's more common to have them than not have them. Okay, and we don't all have pain from it. Motion is lotion, the rest is rust. Look, and it's a nice these are the little one-liners we throw around in the clinic because, like I said before, the fluid between your joints gets stale. Okay, the only way that you can push that fluid around and renew it is through movement. Okay, it's the reason why if you've got your arm in a sling for a few weeks, even though it's your shoulder that's sore, your elbow is also going to be pretty sore after that as well because it's not getting the movement that it requires to continually lubricate that joint. They are made to move. Nearly there, I promise. So this is a cross-section of the thigh. So if we locked me off there at the leg and we took a picture at the top, not quite 40 yet, but it's pretty close. But this is MRI images of a quadricep and the associated ages of the individual. So at the top we've got a 40-year-old triathlete. Now you can see the white little bone in the middle, that's the thigh bone, the femur, and then around that you've got a huge amount of lovely red muscles, and then around that you've got a little bit of fat in the skin. Now we come down to a 74-year-old that's sedentary. Now you can notice that largely now we've got fatty tissue rather than muscular tissue. And then if we go down to the bottom one, there's another 75-year-old that has very similar, even better looking legs than the 40-year-old triathlete. So I guess this slide is just in there to say that age probably isn't a barrier to looking after your muscles. In one respect, that's nice to hear. In the other respect, it means excuses are probably going out the door. It does mean that we can have that in later life. Last slide. And again, lots of data on there. This is from the GLAD program. Has anyone ever heard of the GLAD program? Yeah, a few hands. Anyone ever heard? Normally about 5 to 6 people in the room have. GLAD program created in Denmark, Sweden. This was for people with hip, knee or ankle arthritis. It's an ongoing study. So anyone who joins the GLAD program, we offer Thrive, there's other clinics that do as well. Their data gets uploaded into this study, so it's an ongoing working study, okay? And what we found is that, well, let me take one step back. Over on the left here, there's studies over a 20-year period, so these are the studies listed over here. Sorry, I'm throwing the camera out there. Then we've got a line in the middle. On the right-hand side of the line, that's an exercise intervention. On the left-hand side of the line is a rest intervention. And in every case, exercise is better than doing nothing. Okay, so if you have an injury or you have arthritis, in every case, exercise is better than nothing. Unless, of course, you have a specific injury that your specialist has told you you cannot weight bear through, but for everybody else, you don't get off that easy. Now, this is the data from the GLAD program. Okay, so this GLAD program is only a 6-week program. Okay, so you have your data taken first in the first week, your data taken at 12 weeks, and then again at a year. And this is what they found at 3 months from the program. So you've only done 6 weeks of 3 times a week exercise at this stage. And these are people with fairly significant arthritis. Pain down roughly 30% between the knee and the hip. Medication use down, roughly 40 to 50%. Walking speed improving, quality of life improving, and a lot less people going through surgery. So again, just telling you that if you have degenerative signs in your joints, there is hope, there probably will be a clinic relatively near you that you could at least do the initial program with, and then have some exercises to follow on with yourself. That is it, I think, guys. Thank you very much.
Is there any benefit in taking glucosamine or fish oil tablets to help your joints?
So that was a question around glucosamine and fish oil. Good question. The first thing that you'll always need to do is consider your own situation. So for example, fish oil, a surgeon will want to know about that prior to doing anything because it can actually be blood thinner. So you need to consider your own personal situation. So even though it might be something you can grab off the shelf without a prescription, please make sure that you clear it off because they can have side effects in other ways. But I think you touched upon in general, this is very general advice, I always find fish oil is a good one to go with. The mechanism of how fish oil works is thought to be that it helps with the vascularisation of the bone either side of the joint and helps keep that cartilage healthy. And the other beautiful thing about it is that there's also lots of evidence for brain health and cardiac health with fish oil as well. And it's not necessarily fish oil, it's the omega-3 content in it, which you can get from krill oil and a range of others. As for the others, there's not a lot of evidence for the glucosamine and whatnot. It really is whether you have a deficit of that in your body already. Okay, so for example, if you're having 3 or 4 times a week oily fish, well, you probably don't need to worry about taking fish oil either, but we know that not many of us do that. So, yeah, it's only if you've got a deficit of the other stuff in your body. But fish oil, anecdotally, some of our clients tell us that it's helpful for arthritis, and there is some evidence for it.
I had an arthroscopy on my knee in 2007, and I was told that down the track I would need a knee replacement. We're now 2023, and I'm very careful with my knee. But is there an age limit where, perhaps you should be considering having it now, even though you're not in any pain, rather than leaving it until you're, 10, 20 years older?
Yeah, I mean, it really is an individual specific thing. I get what you're saying, because once you start getting up over towards the 80 age bracket, it'd be a pretty brave surgeon to want to do that surgery at that point. So if you do have a really severe joint and they feel as though there is no other intervention that's going to work, well then yes, you might need to. But what I would say is take a step back and recognise that you're not there yet, and that you probably have a number of years now to try and turn that joint health around a little bit. For example, like programs like this, try that first, and if that doesn't help, well then really you're going as long as you can before you have the surgery. So we know you get about 15 years out of a joint, so you probably don't want to have to go in and have another one afterwards. So that's a factor as well. So I think I've kind of dodged your point, but it is quite individual specific. There are things to try beforehand, but if it is imminent that you're definitely going to require a joint surgery, well then you need to do that in a time in your life where it's going to be safe for you as well. Yeah.
You mentioned that you thought ice is not as recommended now for injuries. What about heat rather than heat as a treatment instead?
Yeah, so good question. Heat, there's still some evidence for heat in pain relief, okay, and in relaxation of the muscle. If you put a heat pack on you, it's very unlikely that it's getting to the depths that it needs to get to have huge amounts of effects on, for example, a large muscle group or on the middle of a joint. But it is good for pain relief. But just remember, you shouldn't use it in that 72-hour window after an acute injury. Otherwise, by acute, I'm meaning after you've just done your ankle sprain or you've just pulled your hammy, because it will increase inflammation and increase bleeding. So
really see the protection part in the same way. Us oldies that put it on before we take the netball court.
yeah, well look, it doesn't matter because you haven't done any injury at that point, so there's no risk of bleeding. So yeah, it's not going to do any harm. If you find that helpful for getting the blood flow going, by all means. Obviously, I'd really encourage you as well to be doing movements specific to netball. I think, I've been out to a bit of netball. Shocking at warming up. Shocking. I think it's probably worthwhile just bringing in some more dynamic stuff beforehand, because it's a winter sport too, on a cold court. So you're probably better off getting a bit more warmth into the muscles and the joints that way, rather than getting the heat pack out and taking the shortcut.
We had a great comment last night. We had a shearing and was asking about warm-ups for shearing, and it was fantastic that you were explaining to do the dynamic exercise similar to what you would be mimicking what you would do for that sort of exercise. So it really is dependent on the specific type of exercise that you're doing, isn't it?
Yeah, it is. I mean, physio is not a hard job in a lot of ways, once you know how it works. And I think that really, once you know what your movement's going to be, you then know what you need to warm your body up to do. So we don't need to be stretching all these different muscle groups beforehand. We need to be practicing what we're about to do and have a feeling of warmth and freedom prior to starting the activity. You should not still be cold prior to starting. Now, if that's in a work environment where you're getting back pain, or you're on the shovel, or whatever you're doing, well then there might be a warm-up associated, for example, the shearer. Maybe it does need to be movements like that with a band or something like that beforehand to warm the body up. Also, stationary bikes are actually pretty good too, or going for a run's pretty good, and vascularising all of these different muscles for warming them up as well. But yes, it needs to be functional for the activity you're about to do. That's why with footy players, you'll see them start off with running, sidestepping, moving forward, moving backwards, all of the different movements that they might do in the practice, and then they'll get into even more functional stuff when they're warm. They'll start kicking the ball, they'll start marking, and then they'll start taking contact through their shoulders, which is another thing that they'll know they'll have to do. And you'll see that with the Thunderbirds as well when you're watching them. They'll go through all those different movements, all those things that they'll be expected to do throughout the game. It's not a hard thing, you just need to break down the activity you're doing and practice that right. And I actually need to run off too, that's why I was first, so thank you very much. What a great story you've done.
Thank you very much, Nigel. 2 nights I've listened to the talk and I've learned more tonight as well as last night, so fantastic information.
Thank you very much. Another small token to say thank you very much. He's come across 2 nights, so all of our speakers have been speaking 2 nights, and so we really do appreciate it. Appreciate your time, appreciate your expertise, so thank you very much. The second speaker that I'm really excited to introduce tonight is Dr. Sophie Polakis. Goes back a few years when I met Sophie back at the Royal Adelaide, and then I met again, we worked together again with her at Flinders. A fantastic doctor, she's a urologist. If anyone was looking at the program on tonight, you may have seen that she's talking about prostate cancer again. I'm not good with my spell check. I should have sent it to my mother to have a look at, but no, she's not doing prostate cancer again, but had a fantastic talk last night. I think the men really enjoyed that topic. There was a few squirmy moments, I think, but it was a great talk. So Sophie works at Flinders Medical Centre as a staff specialist urologist and sees private patients through urological solutions. She looks after patients with general urological conditions such as blood in the urine, prostate cancer and kidney cancer, and also manages services for male and female patients with urinary incontinence in her private and public practice. I'm really excited about introducing Sophie tonight. She's going to have a wonderful talk, and please make her feel welcome.
Good evening, ladies. Thank you, Alice, so much for inviting us to come up for the weekend to Melrose. It's always a pleasure to come to the Mid-North. And as I was saying to the guys last night, I actually did a bit of medical school in Clare. And the reason I became a urologist is because Kim Pacey, who I work with now, consults in Clare. And I sat in on this clinic and I thought, oh, this is the best job in the world. And here I am, 10, 15 years later, still doing it. So I guess I'll talk about a little bit of what I do for work, and then I'll just describe to you as well how, as women in the country, you might actually access our services, and perhaps if any of these issues ring true for you, you know how you might go about seeking some help. And I've got a few handouts that might be of interest to you as you're leaving tonight too. So I'm going to talk about incontinence in a broad sense, because what goes for women also goes for men, more or less. So it's really quite general. And then, of course, women's cancer and urology, because we all know about prostate cancer, and everyone knows about breast cancer, but you know, there are a lot of urological organs that women have as well that also have cancer in them at times. So it's important that you all know how to keep on top of your own health in that respect. And so a lot of women I see, and men, we talk about lower urinary tract symptoms, and we talk about storage symptoms, so you know, being able to hold urine in the bladder. So women and men might come in and say, look, I've got urgency, when I've got to go, I've got to go. I can't stop, you know, keying the door, walking through the freezer section at the supermarket, all those things will stimulate you in your bladder. Frequency, so going frequently, like quite often, you know, every hour or so, every half hour, losing control in those moments. Waking up at night time. So if you wake up once or twice at night, that might be okay, especially if you're avoiding a good amount. But if you're getting up a few times and you're only going 50, 100 mils, and that's, you know, less than half a cup of your glasses, then that's abnormal. When you do go to the toilet, you might find that it's a bit of a stop-start or a weak stream, or you have to change position on the toilet seat in order to make it work. So that's a problem for some people. And then this is more for men, that they might do a little bit. But for women, we might find that we don't empty very well. And something for us to keep in mind is that as you get older, your tissue is not quite as tight and taut as it used to be. And you might find that you've developed a prolapse. And sometimes that prolapse can be holding, sort of pocketing urine in it. So when you do go to the toilet, not everything comes out, you get stuck in this prolapse. So some women actually need to put their fingers in their vagina and push their bladder up in order to be able to pee, or push their fingers down to the rectum to help them empty the rectum. These are common problems, easily addressed, and often, you know, can be addressed without surgery. So that's what's important for you.
I see that a lot in my work as well, people
Yep.
needing to use their fingers to empty the rectum. Yeah.
It's very, very common and not talked about very much until you come and see the doctor. So this is just a bit of a schematic that they come up with. And the top one that I crossed off is prostate issues, because that doesn't apply to people in this room. And if it does, that's okay. But something that we don't talk very much about is detrusor underactivity. So the detrusor is the muscle of the bladder. And with women and men, as you get older, it doesn't work as well. We don't talk about it very much. We talk about overactivity. But actually it doesn't work as well. And if you've had a hysterectomy, when they do that hysterectomy, they might cut some of those microscopic nerves to the bladder that you can't see with the naked eye or with the laparoscope or the robot or anything. And so women might come to me after they've had their hysterectomy a few years down the track and say, I've never quite peed the same. So that's something that's really, really common. So just that you're all aware of it, because I'd say a lot of the women that see me, that tends to be their problem. Is they're, 8 years ago I just stopped peeing right and I don't know why. But there are other things. So some people make more urine at night time. So they pee absolutely fine during the day, and then at night they make more. They make double what they make during the day. That's a different problem. They might have pain. They might have had a stroke. And when you have a stroke, or if you have Parkinson's disease, it makes your bladder more sensitive. So you have trouble with your bladder because of that. Multiple sclerosis can also make your bladder more sensitive and can make your bladder a bit more lazy, so you don't empty your bladder very well. So there's lots of things that can go on. It's a really complicated system. And that's why it can be important to seek help early. There are other things like bladder tumours, urethral strictures, kidney stones that we can fix easily. That it's a good reason to come and see a doctor early, because if you've got one of those simple things, we can fix it. Your symptoms will go back to normal. So you see your GP, they run through a general checkup. So that might involve a bladder diary. It's exactly as boring as it sounds. It's a 3-day list of everything you drink and everything you pee and what time you do that. Urine tests to look for blood in the urine, to look for cancer cells, blood tests to make sure the kidneys are working well, an ultrasound to check the kidneys aren't blocked. And then sometimes you have to come and see me, and I might look inside your bladder with a camera, and I might even do some bladder tests. And I'll talk a bit about that later, just so you understand where that might fit into your treatment. So back to what I was saying, these are the things we can fix easily. So recurrent infections. Lots of women have a lot of urinary tract infections. It's one of the main things people see before. Some people have scarred urethras, so they're a bit sort of tight. Kidney cancer, bladder cancer, they might have blood in their urine, and we've got to rule those things out. And bladder and kidney stones. The reason we want to fix incontinence, so if you leak a bit of urine, it might not bother you. As you get older, you might leak more urine. And what we find is that people who are incontinent or have urgency or go to the toilet a lot at night time, they're actually more prone to falls. And as you'd be aware, if you're older and you start to have falls, that actually impacts on your quality of life and your life expectancy. A lot of people die from a fall. My grandmother died from a fall. So we want to prevent it in elderly people because it prevents a lot of the complications that go around falls and ending up in nursing homes before you should. Also, going to the toilet more frequently is definitely linked with fractures. So people break their hip, they break their arm bones. And that can also see them in a nursing home earlier than they should be. And something that we should keep an eye on, more in men than women, is how much urine you hold in the bladder after you pee. Women can tolerate it more than men can. So men, they run into trouble and need catheters earlier. For women, what we find is that you probably get away with not emptying your bladder completely. But once women start to find you're getting recurrent urine infections, blood in their urine, bladder stones, and those are all reasons that they might actually need to learn to pass a catheter, or we might need to try a few things to make them pee better. This is really just a picture, just to show you that as your bladder becomes more stressed, it develops these little saculations, we call them diverticuli. You can see the muscle gets thicker and thicker and thicker, and eventually that thickness of the muscle causes a back pressure on the kidney, and can cause a blockage of the kidney. So that's why it's important to nip these things in the bud. Women are more likely, in general, to have an overactive bladder. So that's the key in the door, got to rush to the toilet, wet myself, can't make it on time. And that's something that will happen with age and time. Men are more likely to have enlarged prostates, which can cause the same problem to them. So once the enlarged prostate gets to a certain point, it actually affects their bladder function and they have both issues. They can't pee, and when they do pee, it goes everywhere. So we treat overactive bladder mostly with tablets. So this is a table that I use for my patients, and I've got some handouts at the front there. I don't expect anyone to take business cards or the pictures of myself. I'm not sure my secretary put them there because you're not going to drive to Adelaide to see me. But at the back of the sheets, And I've separated them for you. There's actually a copy of this table here. So if you're, just to have a squeeze at it later, just grab one on your way out. And also please take the pens, they're really good pens. I don't want to take any home. So I've explained to patients that some people have stress incontinence, that's the link with cough, sneeze, jump. Some people have overactive bladder, that urgency frequency up all night. We myself can't make it to the toilet. The overactive bladder, there's a lot of first-line therapy we can do without tablets. And the most important thing, you guys are in a rural area, the first person I would see after your GP has made sure that there's no signs of cancer in their ultrasound and urine test is the physiotherapist. There are pelvic floor physiotherapists. Nigel told me there's one in Jamestown, I think one in Peary. You want to see a women's health pelvic floor physiotherapist. They can actually sort out a lot of this for you. They can also usually fit pessaries. So if you have a prolapse, they'll diagnose the prolapse, they'll put the pessary in. You don't need to wait to see a gynaecologist. Not everyone's GP does it. So see the physiotherapist, they'll get you sorted. And once you get to a point with the physiotherapist where it's really not as much of an improvement as you like, then you can come to see us. And at least we know that all the basic stuff's been done and been done well. So overactive bladder, we tell everyone, stop smoking. If you're postmenopausal, start using vaginal estrogen cream. And that's safe even if you've had breast cancer, because it's just absorbed at the skin and the vagina, it doesn't go into your blood. Weight loss, avoiding irritants, so caffeine. We love caffeine, we love coffee, but it does make people's bladder go crazy. And then we add in tablets. Now my favourite tablet is something called Vetmega. Unfortunately, it's $50 a month. It's expensive. But I tell patients, look, try it for a month or two. If it hasn't worked in those 2 months, then we know that it's not going to work for you. It has the least side effects. I like it in old people because it doesn't affect their brain, whereas the other tablets we've got affects their brain. So I try not to use that as much as I can. And then we go to third line therapies. The physios, they can actually do a little bit of this. They can do some of the acupuncture. Have you heard of TEMS machines? Who's got a TEMS machine? Yeah, they're really common. And a pelvic floor physio can actually teach you how to use your TEMS machine to stimulate the tibial nerve at your ankle. Now what happens is the nerve leaves your back at the S3 nerve root. It goes to your bladder, and then from your bladder it shoots off down to your ankle. And if you stimulate it down to the ankle, it actually sends all of these impulses back up via the bladder into your spine. And for some people, that can work really well at controlling overactive bladder. You can do that at home. So there's all these little tips and tricks that you can tap into in your local area. If the tablets don't work, then people come and see me. And I might do Botox into their bladder, so instead of putting it into your forehead, put it into your bladder. And the other treatment I have, the other surgical treatment I have is actually a pacemaker, and I'll talk a bit more about that in a second. Stress incontinence, there are surgical and non-surgical treatments. Pelvic floor physio will sort you out for the non-surgical treatments. They might put a pessary. There's all these devices that are not pessaries as such for prolapse, but they're little rings with knobs that you can put in the vagina that, for example, if you're only leak when you're playing netball and you only want to sort things out when you're playing netball, you might just put that in while you're playing netball. And then once you've finished your game, you take it out and you get on with your life. You don't have a surgery, you don't have an irreversible treatment, you just have a solution for a particular activity. But surgical options, which I'll talk about very briefly, include bulking agents, slings, sphincters, and also a little sort of stitch that the gynaecologist can put in with the keyhole surgery. But the bulking agents, think lip fillers. Instead of a filler in the lips, I'll put a filler in the urethra just to give you a bit more resistance. Lasts about a year. Reversible. So this is the tibial nerve stimulation. So we can do it in the clinic. You've got to drive to Adelaide every week for 6 weeks. I don't think anyone's going to do that, but you might be able to do it at home. And that's the TEMS machine. This is the pacemaker. So there's a little pacemaker device that we can put in the back that will give this constant stimulation, this electrical stimulation down your S3 nerve root. And that's a good treatment for overactive bladder. It works in about 70% of people. But it can also treat those women who can't pee very well, so what we call non-obstructive retention. So sometimes we have these young people who might have had a spinal cord injury or some issue in their youth, they can't pee, they need to use catheters to empty their bladder, and this will really fix things for them. The beauty of this treatment is that we do a trial phase. And the trial phase, you have a bit of sedation, we put in a little needle into your back, we send you home with a little wire that's taped to your back, and you stay at home for 7 days, you don't shower, you sponge bath, and it trials the treatment. And then you come back to my clinic and I'll pull it out in the clinic, you don't need another anaesthetic. And if it worked for you, then we say, okay, great, that worked. Let's think about, are you happy to have a pacemaker? If it didn't work, then we know it didn't work. But it's a really, I think it's not so much low risk. It is low risk, it's just a needle in the back. There are very few complications, it's a trial. I think it's a really acceptable and easy way to try something that's a little bit scary. No one wants a pacemaker if they don't know if it's going to work. But it's a way that we can trial a treatment that previously was very difficult to sell to people. Stress incontinence, this is the filler. As you can see, those little blue dots are the bits that kind of bulk up the urethra. I actually have a young lady who's just had her first child, and she's been incontinent since that first child, and despite everything the physios have done with her, she's not quite right. She's going to have more kids, so we've actually gone for a bulking agent for her, because ultimately she's going to need something more permanent, but who knows what the subsequent pregnancies are going to do to her pelvic floor. So we've gone for a bulking agent, and we'll just monitor things. She can get that topped up every year until she's ready for something more permanent. And then we've got the slings, there's the mesh sling, and there's fascial slings. And fascial means a piece of your own tissue that we use and we put in that configuration to just hold up and compress the urethra. Any questions? So what's our goal? We go to urologists, as doctors, we just want to get you to a point that you're comfortable, that you can get on with your activities of your daily life, whatever you need to do. It's a very different conversation that I have with someone who's a gym junkie and works as a personal trainer compared to someone who's in their 60s or 70s, looking after grandkids, running around after grandkids. It's different. Everyone has a different goal. And certainly around the issues of mesh and fillers, everyone also has these preconceived ideas about what they're happy to have in their body. So it's an individual discussion. With patients, so let's say, for example, you think, yeah, I've got this issue, I'm seeing the pelvic floor physio in Jamestown, it's not working, I need to come down to Adelaide and see someone. There's a couple of urologists who will do this work. And for most of us, I'd say that if you wanted to make an appointment to see us, being country people, we'd try and see you on the same day and do any tests that you need all on the same day. So when women have seen the physio and they're ready to talk about the next step, I do a cystoscopy where I look inside your bladder with a little camera just to check internally that everything's okay. And then I do a pressure test where I put a little catheter in your bladder and a little one in the vagina, and I fill your bladder with fluid, and I measure the pressure so I can see how much incontinence you have from column A versus column B. And then we can work out what the best treatment is, because most women will actually have a bit of both. And you want to treat one before you treat the other. So that's about an hour, 2-hour appointment that you'd have down in Adelaide in order to sort that out. And you come out of that appointment with a treatment plan from there. So that's it for incontinence. That was a Cook's tour. Whirlwind, my apologies. Take the hand out home and have a read of it. Women's cancers, this is the last slide. These are the 3 that we see. Ureteric cancer is really rare. Bladder cancer is not very rare. Bladder cancer is quite common in smokers, 6 times more common in smokers than it is in non-smokers. So it is quite common in the Australian population. It presents with blood in your urine. So if you see a show of blood and you don't have a urinary tract infection, then you need to see a GP to get a CT scan and come to see me for a cystoscopy. You can get a cystoscopy in Clare with Kimpizzi, you can get one in Port Pirie, you can get one in Port Augusta, you can get one in Whyalla. So we do a lot of these tests locally. And for people with kidney cancer, it's one of those things that we used to find when people had blood in their urine. It was this massive cancer because it has to get to a certain size in order to leak blood. But nowadays, because people are getting a CT scan for lots of different reasons, we're diagnosing them just by chance. People will have no symptoms. And of all my cancers that I work with on a daily basis, this is probably the best one to get because it's contained in a special pocket in the tummy. It's away from everything else. It has to get to a really big size to be a problem. We can often just shave it off or remove it in part and keep the rest of the kidney. So it tends to be something that we find by chance. And so people are always very shocked and very upset when they see us and need to have treatment. But in many patients, it will be curative and they never need to think about it again. And that's me done. Thank you for your attention. Any questions?
What made you choose that topic
That topic?
to work with?
Well, you know, incontinence, when we train as urologists, we don't see that much of it because you can imagine the amount of cancer work that goes into the public system. It just overwhelms all of this stuff. And so we don't get a chance to really work with it. But then when you finish your training and you're a woman in the urology field, well, there's lots of women patients, and a lot of female patients, I think, prefer to see a woman sometimes. So I think it's become one of those things, it's become a big part of my practice just by chance. And it's a lovely way to help people, but I must say, it is a much more stressful thing to deal with than cancer. Because cancer has to come out. You know, cancer has to be sorted. You've got a goal. You can't argue around it. But if something goes wrong with this surgery, then it's really, as a doctor, you just feel terrible that you've done something or you've given someone a treatment, and things don't go to plan all the time. Surgery is surgery. So there's a lot riding on it. So it's a very important thing that I do. It's not the easiest part of my job, but it's an important service to offer.
I have one thing. I see one of your first line management was bladder retraining. What are your thoughts around when people or patients have catheters and doing a flip flow bladder training to get the catheter out? Does that work or?
When people have a catheter, it would usually be because they can't empty their bladder for some reason. The safest way for them to empty their bladder is to learn to pass catheter themselves, because then the bladder mimics the normal activities. The bladder is supposed to be the storage vessel. So it has to fill, it has to send your brain a signal that you need to pee, and then it needs to be able to empty. If you can't empty, then you either need a catheter in or you pass a catheter every time you need to use it. I think that the flip flow gives the bladder the better chance of maintaining its function. And for those who don't know, a flip flow is a little valve, like a tap, that we put on the end of a catheter that you can turn on and off. So instead of having this tube coming out of your bladder strapped to a bag on your leg, you have a tap on the end of that tube. So your bladder will fill when you get this sort of signal that you need to pee. So you can go to the toilet and you can open the tap and you can drain your bladder into the toilet. And that just maintains function. So where I can, I try to encourage people to do that. I've got a lady at the moment who's had a catheter in for 30 years, and no one ever explained to her that she should have a valve on it, open, close, open, close. And this bladder's become this contracted, tiny little thing. So every time her catheter blocks, she's in agony. She has no capacity for that bladder to stretch. It's become this little calcified ball. And we really have no choice now but to give her a new bladder made out of bowel so that she can have a stoma bag, because the complications just from this catheter, it's not cancer, but she's going to need a major surgery just to get some quality of life back. So flip flow if you can, I think is ideal. Thank you very much, ladies. Enjoy the rest of the evening.
Thank you very much, Sophie. That was another wonderful presentation, and I'm sure we've got a lot out of it. I'm sure there's going to be lots of talk in the next 5 minutes. And Sophie, her husband Simon, will be talking to us later in the evening. They're doing a bit of a tag team process. They've got 2 beautiful twin daughters. So I'm going to give thanks Sophie again tonight, just before she leaves, and give her a small token to say thank you. But yeah, please give her another round of applause. Another quick 5-minute break before we get on to the third. One is inflammatory bowel disease, one is gut health in general, and the other one is bowel cancer. And bowel cancer, alarmingly, Australia has one of the leading rates of bowel cancer worldwide, which is shocking, really, when we're a developed country with the technology that we have, and we still have such high rates of such a sinister disease. And in terms of gastroenterology in itself, it's a lot of the symptoms that I see and that people can have are really things that people don't want to talk about. A bit like Sophie's area in terms of incontinence and urine leakage and things. They're not topics that you generally want to talk about over a drink on a Friday night at the pub, or even wanting to see your GP about, and let alone sometimes wanting to come and see a specialist about. If we think about poo, When we have babies, we talk about it all the time. Have they pooed? How much have they pooed? They haven't pooed. How can we get them to poo? Then there's no explosions that we all, I'm sure, have experienced at some stage. And then they grow up and become toddlers, and then it's about potty training, and we're talking about their bodily functions all the time. And then you get to where I am at the moment, and they're talking about it all the time, and their jokes are relentless, so I'm going to work talking about it. I come home, I've got 3 boys that are talking about it. But we're quite happy in some ways to talk about our children's bodily functions. When it comes to ourselves, it's a different issue, isn't it? And even then when, you know, if we do have children and they grow up, then suddenly we're talking about it less and less, and it is becoming sometimes a more taboo topic and we don't want to talk about it. And I think over the generations that has improved. You think about grandparents and great-grandparents, and it really wasn't spoken about at all. And unfortunately, there have been a lot of things that have been missed, some simple things that could have been easily fixed, and obviously some more sinister and deadly things. But I really want some of these information nights to be able to break down that barrier of being embarrassed or tentative to talk about these things. And even if you still don't want to talk about it among friends or families, at least you've got the confidence to go and see a GP and say, hey, is this normal? Or if it's not normal, can you help me and see if I can fix it? Because the majority of the time, it can be fixed and it's nothing sinister. But on those few occasions that it is something sinister, pick it up early and we can get on with it. So that's why I've decided to do bowel cancer as the main topic, and then a little bit of gut health at the end. So what is bowel cancer? Well, I'm going to take a step back and let's say, well, what is our bowels and where are they? So the first diagram on the right shows the gastrointestinal tract from the mouth right through to the anus. So down the esophagus into the stomach, which links up to the small bowel, the bag of worms in the middle, that then connects over onto the right side of the large bowel, where you've got your appendix, if you still have that. It goes up the right side, underneath the ribs, down the left, and then out through the rectum, which I've then superimposed on this side. So this is the large bowel, this is the colon, this is colorectal cancer. This is where bowel cancer occurs, in the colon or the rectum. And what is bowel cancer? Well, bowel cancer is an abnormal cell growth in the lining of the bowel, of the large bowel, of the colon or the rectum. In our intestines, in our small and large bowel, we lose all of our cells in the bowel about every 10 days. Obviously not all at once, sort of in a sequential fashion, and it comes out through our faeces with waste products and bacteria and viruses and fungi. Now, if one of those cells in our large bowel, and we're talking about the colon now, decides that it doesn't want to die, it's developed some type of mutation or damage to the DNA, it's going to stay there. And then if that cell stays there, it's going to divide into 2, into 4, into 8, into 16, and then my maths is going to escape me a little bit. But then you've got what happens then is a group of abnormal cells then sitting in the lining of the bowel. Now this initially is what we call a simple polyp, which is a benign growth, but then over time, and not all of these polyps, but over time about 1 in 20 could potentially then continue to grow, continue to gain more mutations in the DNA and become more abnormal, and perhaps gain some advantage, some growth advantage, or advantage then to feed off of blood vessels, and then eventually turn into bowel cancer, and then gain further advantage that it may even spread after that. And that period of either developing a polyp or then when it progresses is where we want to intervene and try and prevent that progression. We don't know which of these polyps could lead to bowel cancer, so we would like to remove all of them if they're there. As I mentioned, Australia has one of the leading rates of bowel cancer, so on average in the recent years over 15,000 cases of bowel cancer are diagnosed each and every year in Australia. And of that, over 5,000 people die each year. And I think alarmingly, it's not just an old person's disease. There is an increasing rate of people under the age of 50 being diagnosed, about 10%, and of that, 5% of people are dying that are less than 50. So if we think about those rates, it's about 1 in 15 chance that we may get bowel cancer in our lifetime, and it does differ depending on your risk factors. So it's an extremely important disease, and I think that there is obviously a huge amount of research going into it all around the world. If we go back to the polyps, I'm sorry, the people on the sides that might not be able to see this, but a polyp, as I said, initially is a benign growth and it's very small. So the majority of polyps that I see in the bowel are 1 or 2 millimetres, but they can get up to quite a few centimetres in size and still be benign before they lead to bowel cancer. Look away now. I have got a couple of photos and I thought that it would be really important for some people to actually know what it looks like in real life. So these are a couple of polyps that I've taken off over the last 10 years. Extremely exaggerated example, and in terms of these are not the normal polyps that I take off, these are quite a few centimetres in size. And you can see on the right, around the edge, it's a nice healthy bowel lining with nice beautiful blood vessels, and obviously the thing in the middle is abnormal. And on this one on the left, you can actually see that it comes out on a stalk. So polyps can either be flat, sometimes they can be depressed, sometimes they can be a little bit of a gentle rise, or the other occasions they can be like a mushroom on a stalk. Polyps are quite common. About 15 to 40% of people will have bowel polyps in their lifetime, and more common in males. So who gets bowel cancer? Bowel cancer affects male and female, young and old. We think that men are at more increased risk of getting bowel cancer, probably because of their risk factors, their modifiable risk factors. So we know men are more likely to drink more alcohol, more likely to smoke, and more likely to consume red and processed meats, putting their risk up. It is a disease that is predominantly in the old. Risk increases quite sharply after the age of 50, and that's why the National Bowel Cancer Screening Program targets 50 years and above. And the peak sort of is around the 70 to 80 year mark, but it is increasingly and concerningly getting more frequent in less than 50-year-olds, the young onset. Family history plays a part, so about 30% of people that are diagnosed with bowel cancer will have a family history. Now, that is separated into the family history where maybe one grandfather or an uncle had bowel cancer, which puts your risk at that slight increased risk, compared to people that have their mother, their mother's aunt, their mother's 2 sisters, and their mother's mother that all had bowel cancer. And usually in that scenario is what we call a hereditary condition, where there's a specific gene that we can test for that is being passed down through generations, and that puts you extremely, very high risk. And hopefully there's talk amongst the family that you know if you're in that situation, then the screening programs will start earlier. If we pick up bowel cancer early at an early stage, 99% are curable. But alarmingly, less than 50% are picked up early. And why is that? Is it that people aren't presenting with their symptoms and talking to their GP when they should be? Or is it because of our screening programs aren't working? And unfortunately, with our National Bowel Cancer Screening Program, the uptake of using that program is less than 50, or around about 50%. So we need to really work on that. So what are the symptoms that could potentially be a bowel cancer? Well, there is a range, and usually all these symptoms may relate to something quite benign, okay? But they could possibly be a bowel cancer, and they should lead you to go and see your GP and have another chat about it. Blood in your stool is always abnormal. Usually it's caused by hemorrhoids, which are benign piles. Many of us may have experienced them in pregnancy, and they're very common. But if you've got blood in the toilet bowl, how do you know that it's caused by a hemorrhoid or it's caused by something more sinister? So until you have a test that can look in the bowel and say, yes, you're right, it is hemorrhoids, we don't really know. And what's to say that someone might have hemorrhoids, but then they also might have bowel cancer there at the same time? So blood in the stool is always an abnormal feature, but it might not be sinister caused by a bowel cancer, but it should always be investigated. Having a change in your bowel habit that's longer than about 2 weeks could be a possible sign. So we've had a lot of gastro in the mid-north. Hopefully everyone resolves after a couple of days. But if you've got a change in your bowel habit that's abnormal for you and lasts for a period of time, it could be potentially a trigger, an alarm feature. And that really comes back to knowing your own bowels. So I see a broad range of normal bowel habit. So someone's normal bowel habit might be once every 4 days going to the toilet. It might be 2 or 3 times a day in the morning. It might be you get up, go for a walk, have your cup of coffee, and it's like clockwork. But then suddenly, if your clockwork type bowel habit then suddenly changes to going 3 or 4 times a day, and it lasts for quite a few weeks, something's abnormal. It might be an infection, it might be because you've started a new medication, it might be a diet, but it's abnormal for you, and it should prompt you to go and see a GP. And hopefully then we'll try a range of different treatments, investigate it. If there's anything that's alarming there, you might get a referral off early, but you might have a treatment plan. You go home, if it doesn't sort itself out, go back and talk to your GP and say, look, I tried this, it's not working, what do we do next? Okay, we shouldn't be sitting on things if we think that they are abnormal. A change in shape or appearance of the stool is very important. Abdominal pain and swelling, again, important. It could be caused by a range of different things, but if it's there for a long period of time, it should prompt you to talk to your GP. A pain or a lump in the anus or the rectum, again, could be hemorrhoids, but it might not be. It might be something else. I think the bottom one is very hard, isn't it? Tiredness. I'm tired. I feel like I'm tired all the time sometimes. And tiredness can be caused by a range of different things. But if it's linked with being anemic or low in iron, or if you've got unexplained weight loss, it really could be a sign that something else is happening. Now, there are a number of things that can put our risk of bowel cancer up. There's things that we've talked about already, in age and family history, but there are things that we're doing to ourselves, or that we can at least modify, that put our risk of bowel cancer up. So we call these modifiable risk factors. So smoking, any smoking is bad, okay? But the more you smoke for the longer period of time, the worse your risk is. There are about 70 carcinogenic agents that can damage your DNA in your cells, making those changes to cause that cell to stay in your body and then divide and then gain sort of further advantage to stay in your bowel. Alcohol, as we sip on a beautiful gin, any alcohol, even 1 cent a drink a day, can put your risk up. Now, 1 cent a drink, a week or a month, obviously is going to put your risk at a minuscule level up. That's not, I don't know whether that's good English, but it's going to put your risk up, whether you decide to think that's important or not. As long as I think we abide by the Australian guidelines, so less than 2 standard drinks of alcohol per day with some alcohol-free days. Obesity increases your risk, particularly central obesity around the gut if you've got an increased waist circumference. That generally leads to insulin resistance, and then our pancreas trying to pump out some hormones which can relate or trigger off bowel or increase the risk of bowel cancer. And finally, excess processed or red meats. We had a chuckle last night, didn't we? Kerry, the men were enjoying some beautiful salamis and beautiful red meat and processed meats, and we consume them as well. But I think everything in moderation. And we're really talking about excess, having it on a daily basis and consuming very large amounts, but it has been shown to increase your risk. The non-modifiable risks we talked about before, age, family history, hereditary conditions, where there's a known gene that can cause it. Also things that affect the bowel for a long period of time can increase your risk, so inflammatory bowel disease in certain instances. If we come back to age and the young onset, we really don't know exactly why the rates are increasing. We think that it potentially has a link to our risk factors, so in this day and age, unfortunately, we're leading a more sedentary lifestyle with more processed foods, more red meats, more alcohol, more smoking, and that potentially has a link, but there possibly is more to it, more genetics and something genetic-wise at the cell level that we haven't yet found out that's increasing that risk in that age group. And this was just a graph just to show you, highlight that after the age of 50, it is quite a sharp increase up with the risk of bowel cancer. So how is it diagnosed? I think we can split this into 2 groups. So the first group are the people with symptoms that potentially something could be wrong and how they might be diagnosed, and then the group that are in the screening group. So you might have screening tests if you're over the age of 50 and you get that lovely 50th birthday present in the mail with a stool check to check for any blood in the stool. Or you might be participating in a screening because you have got a family history and you've been told that you need to start screening early because you're at higher risk. And if you have symptoms of abnormal bowel habit or blood in the stool, you might Your GP will do a thorough investigation, a thorough history and examination. You might get stool tests taken off for testing of infection or blood. You might have some blood tests taken to look whether you're anemic. You might have some imaging like a CT scan or possibly an ultrasound or an MRI. But usually if bowel cancer is considered something that in the differential that it might be, or if your screening test has shown that you do have a little bit of blood, you're up for a colonoscopy. I've got my ball price. So I do have advantage over Sophie. She was a good speaker, but the men said that when I showed them the colonoscopy yesterday, they were a little bit squirmy. There were a few people that yelled at who was going to be my guinea pig. But Sophie does these without anaesthetic. I don't. These procedures are safe, relatively safe, or very safe. They're usually pain-free. You're under an anaesthetic and it takes about 20 minutes. And the worst part about the procedure is the bowel preparation that you have to have the night before. It's bad, and I apologise to every single patient that sees me. No one likes to come to see me to have one of these, but they are simple on the day and generally are pain-free. So this is my colonoscope. This is hooked into a machine behind me with a light source. I have 2 dials on the right, which move the telescope back and up and down, left and right. I showed the boys this on the weekend, and I was moving it around, and I went boom. He just about jumped through the roof. And I can torque it as well. And these are used in lots of other areas of not life, but mechanics use these, plumbers use these. So it's just to look through a hollow tube. So I'm going up, around the bowel, and down. It's got a light source, so it's dark in there. I need to see what I'm doing. I've got a port here, so I've got 2 channels that are through here. One I can suction things out, and one I can use with instruments. So I can put an instrument down here, and if I've got a polyp, then I can cut it out. It's a serrated edge with a little wire, or I can take biopsies and small pieces of tissue. It is 1.9 metres. I don't generally need to use this. Usually only about 70 centimetres. And as I said, it's pain-free. I know no one likes the idea of having it, but to me, if you weigh up the risks and benefits, the benefits outweigh the risks if it's going to be something like bowel cancer that we're talking about. So if I find a bowel cancer, I'll take some biopsies, some samples of tissue which need to be sent away to the pathologist to look underneath the microscope and confirm that yes, unfortunately, that is the diagnosis. And then after that, generally we get imaging, so CT scans to see if it has spread. And then all of that information is collated, and there's a meeting, a multidisciplinary meeting where gastroenterologists, surgeons, pathologists, radiologists, and then cancer treating doctors, oncologists and radiation oncologists sit down, take all the information and come up with the best possible plan to give you the best prognosis. You'll also be staged at that stage, and as I said, if we can pick up cancers early at an early stage, there's a 99% chance of cure. Treatment generally involves surgery, taking out that bowel cancer, and depending on the stage and other factors around in the patient, they may have what we call adjunctive therapy, additional therapy. Traditional things like chemotherapy or radiotherapy can be used, but we've also got newer things like immunotherapy and targeted therapy. But we don't want to get to that stage, so how do we reduce risk of bowel cancer? One is the participation in the National Bowel Cancer Screening Program. So this is a program that is fully funded by the government, where they send out stool tests after the age of 50 every 2 years until the age of 74. They are quite ageist, and therefore if you're a fit 75-year-old and you're wanting to continue those stool tests, then that's a discussion with your GP, and you can certainly continue it after that. It checks for blood in the stool. We know that bowel cancers and the precursors to bowel cancer, those polyps, can bleed, and this test can pick up the most minute amount of blood in the stool. If you're seeing blood in the toilet bowl, you don't need this test. You jump that test and potentially go straight to a colonoscopy or other tests. So this is for someone picking up a potential bowel cancer before they have any symptoms. Now, of all people that do a fecal test to look for blood, about 10 to 15% are positive, and positive doesn't mean yay, you're free to go. Positive actually means that you've got blood in it, but it doesn't mean you've got a bowel cancer. So if you've got blood in your stool, maybe there's about a 20% chance that you might have, 20 to 30% chance you might have a polyp or a growth, a benign thing that I can generally remove. There's about 3% of people will have a bowel cancer, but hopefully it's at an early stage that we can remove it. So that's the National Bowel Cancer Screening Program. Actually in America, research shows that because of this increasing incidence of diagnosis below the age of 50, they've shifted their program back to start at the age of 45. But unfortunately in Australia we don't have funding to provide that free of charge, but it's encouraged that GPs will start to do it after the age of 45 every 2 years. And this is different for the people that have a family history of bowel cancer. That's very much specific to their family history, and it might start very early, and it might start with a colonoscopy from the age of 20, depending on what they're, or 25, or maybe even younger if there's a significant hereditary illness that's been diagnosed. So that's one way we can reduce the bowel cancer risk, but unfortunately the uptake is very low. You often hear people, oh yes, it's in the cupboard somewhere, or I've left it in the car, or I don't need it, I feel fine. We need to change that attitude. The other thing is to reduce our modifiable risk factors. So we've talked about alcohol and staying within the standard drinking guidelines. No smoking well, smoking at all is bad, and we need to try and reduce the amount you're taking, but eventually stop it completely. Exercise has been shown to reduce your risk of bowel cancer by about regular exercise, not the once every few months, but regular exercise, possibly reduces it by about 15%. So you've seen Nigel's recommended guidelines before, was it I can't remember, yeah, 300 minutes, not a day, but a week, yeah. But any exercise is good, so just start. You don't have to start with 300, just start low and then build up from there. Ideal weight is important, we've talked about that before, and diet is really important. So yes, we've talked about processed meats and red meat, trying to limit that to no more than 4 serves a week, 350 to I think 500 grams per serve. But also other things. So there's evidence behind eating, consuming fresh fruit and vegetables to reduce your bowel cancer risk, and getting adequate dairy is also the other thing. Now I could talk about gut health all day long, but you've got some excellent speakers coming up next. But I'm passionate about gut health because it makes sense. What we're putting in our mouth, or what we do to our bodies, has an effect on us, doesn't it? Usually it does. And it might not just be our gut, it might be affecting other areas of our body. We've got this wonderful gut microbiome, and Catherine, I talked to your ladies at the Wilmington Tennis Club about this, and I'm not spending as long as I did on that day, but you've got a microbiome with trillions of viruses, fungi, bacteria sitting predominantly in our large bowel, not so much our small bowel or our stomach. Which, if you had to add up all the cells in that gut microbiome, it's about 50% of our body's cells, which I think is fascinating, and probably weighs about 2 kilos if we had to add it all up. So it's huge, and the research is just exploding, which is not a great word in gastroenterology, but exploding, learning more and more about our gut microbiome and understanding it's not just causing or affecting our gut symptoms and illnesses, but also having to links with mental health, obesity, diabetes, all these other things. So shouldn't what we be putting into our mouth be just more important than trying to avoid diarrhea or feeling a bit bloated, or having some minor symptoms, which are not minor for some people they're more severe. So the gut microbiome starts in utero, so it starts in the uterus, and for the first year pretty much mimics the mother's microbiome. But once you start feeding that child and having external exposures, it's going to start to change. And we think that it's probably fully developed by the age of 3. Over our lifetime though, it will change depending on what we put in our mouth. If we smoke, illnesses, life stresses, medications, antibiotics, it's going to change over time. And I really struggle sometimes with people who say, well, what do you eat? Do you eat red meat? Because I've just told you that it increases risk of bowel cancer. But then on the other hand, I'm telling patients that come to me with anemia and they're low in iron to then increase their iron levels, and so therefore increase your red meat. We know coffee can stimulate your bowel and stimulate your bladder, like Sophie just mentioned before. But then isn't there studies that I saw in Sunrise that showed me that coffee's actually good for your liver? And alcohol, I've been saying on a few occasions, but then red wine's got antioxidants. What do you do? And I was saying last night to the men, there's this great video, I'm not good with technology, but there's this great video that I really wish I could put up and link to it, that showed over the decades this couple, or this woman serving out food to her husband, eggs and bacon. And they started off in a generation where, eggs and bacon are really good for you, plenty of protein. And then the next decade, he was just about to sit down to it, she ripped the plate away, no eggs for you, so you increased your cholesterol. And the next stage she put it back saying, eggs are healthy for you, but you can't have the bread, the gluten's bad for you. And it just made a mockery of research and just showed that things are changing all the time. So what do we do? What does that research show now? Well, obviously some people have certain symptoms and illnesses that they need to avoid certain things. So people that are lactose intolerant benefit from avoiding lactose. People that have celiac disease or are gluten intolerant are generally better if they avoid gluten. But for the general population, we think that probably the Mediterranean style diet is probably the best for us. So this diet's based on plenty of fresh fruit and vegetables, nuts and seeds, legumes, good fats and oils, some white meat and fish, but minimal red meat and processed meat, and certainly overly processed foods, artificial sweeteners and things like that to extreme, only on rare occasions. So I know there's probably a few dietitians in the room, and I'm certainly not qualified in this area, but generally I say if we're wanting to do that, try and shop around the outskirts of your Woolworths or Coles or Foodland, because generally that's where the fruit and veg and dairy and I think hopefully I mentioned dairy, but meats and fish are. So that was a bit of a whirlwind, and I really like this slide because you're nodding. I know you're nodding. But I hope that gives a little bit of an insight into gut health, and I hope that it really promotes the importance of bowel cancer awareness and to have the ability to feel comfortable in knowing what your own bowel habit is and feeling comfortable if it is abnormal, either talking to your family, talking to your friends, but at least going to see a GP, and if it doesn't get fixed, then going back, it might need that next level of investigations. Good. Any questions at all?
Yeah. If the bowel cancer does run in the family, how old would you go to the test?
Yeah, really good question, and it's really patient or family specific. So as a gastroenterologist and sometimes GPs, we have these tables that calculates how many members of your family might be affected and what family degree they are. So is it a first degree member or is it second degree, and also their ages, and then all of that information tells us generally what risk you are. Are you extremely high risk, are you at moderate risk, or are you at low risk? And if you are at high risk, generally speaking, again it is specific to the patient, but probably a colonoscopy 10 years earlier than the earliest family member that was affected. So for example, if you had a family member that was affected at the age of 50 and it was your first degree relative, possibly you might need one at 40. But again, it's something that you need to have a chat to your GP about.
Alice, what's your, it's a bit of a big question, probably a whole topic on its own, but just a thought on probiotics for the kids or for adults? And
yeah, I should have prepared this earlier, Carly, and I thought you might be here. I got this question last night. So I think there is good data behind the idea of probiotics and prebiotics and things like that to promote healthy gut bacteria. And in certain groups that are at risk for certain things, just for example, if someone had an antibiotics and almost a cleaned out their good bacteria in certain circumstances, yes, it really is important. For the general population, it's right in what it's trying to do, but I think we're a long way off where we need to be. So there is so much evidence now that one day we will be able to give a stool sample. It will print off the proportions of what good and bad bacteria there are, hundreds of thousands, and then it will spit out a tablet that will be tailored to you and your probiotic or prebiotic that can regulate and bring yours back into the normal range. And I think we're still a while away from that, but it's not too far on the horizon really. Day to day, should we be doing it? I think if you eat a healthy, balanced diet, you should be getting those good bacteria then. If you have symptoms that may mean your gut microbiome is upset, you could potentially try in addition to try and correct your diet. If that answers that question. But you probably could talk about this before for me.
No, I genuinely have no idea. And I just think post-gastro, which you're talking about, like for kids or, and then I think it's tricky because it's so exciting when someone asks about glucosamine. It's marketed that you need to have it. But we're not.
Yeah. So I in the general population that I see, irritable bowel syndrome I see a lot, and this is where I tend to use it. I usually say try it for a month. If it doesn't seem to work, I usually say you don't necessarily have to continue it thereafter. They are expensive too.
How does government funding for bowel cancer compare to, say, breast cancer? You hear a lot about, funding for breast cancer, but not so much about the bowel.
So in terms of the National Bowel Cancer Screening Program, that's fully funded after the age of 50. Some patients though don't get those bowel cancer screening tests, and I don't know why. Sometimes it is interrupted if you have had a colonoscopy and then they assume that you're on a program with your gastroenterologist or surgeon, so therefore it's not sent out. And if you don't get it, you can get it from your GP or from the cancer or from Rotary. Does that answer it? No. I'll talk to you later. Sorry. Okay, let's have, it's getting really late. We've still got two fantastic speakers. So I was going to say half an hour break, but let's probably 5 or 10 minutes again, and then we'll kick off with the next speaker. I'm very excited to introduce the last speaker, Dr. Paula Kitto. Paula, I was just trying to work out before. Paula and I first met, and we both teach the rural clinical school of 50 students. And I first met her a couple of years ago after, I'm not sure how long after she'd come back from Somalia. She's been there on a couple of occasions. And listening to some of the stories, it was just mind-boggling, and I thought that it would be a great opportunity to share some of her experiences, and she may not be sharing some of her experiences, and you'll soon see why. And Paula, I've then gone on to, we say we're co-organisers of the course. I'm really her lucky, I think. She does most of the work with the Vicky of Medical Student in one of our courses, but I really enjoyed working with Paula over the years. And so Paula is a rural generalist and a GP obstetrician based in SA, and she splits her time between Kadina, Wallaroo and Port Lincoln. She was born and raised in rural SA prior to moving to Adelaide to undertake her medical studies at Flinders University. Paula undertook her postgraduate studies in the NT before moving back to SA, and over the years has worked in most states of Australia in addition to several overseas countries. I'm really excited to introduce Paula, so please give her a warm welcome.
Thank you, Alice, and thank you to all of you guys for turning up, or all of you ladies for turning up. And this is something a little bit different to what everyone else has spoken about, but hopefully I won't put you all to sleep and we won't take too much of your time. I just want to start off acknowledging traditional owners and custodians that are here on today, or whose land we're on today, and recognising their connection to this land, to the waters nearby, and acknowledging that sovereignty was never ceded. I want to pay respect to elders past and present, and extend that respect to any First Nations people who might be here today. So, how does a GP from Australia go somewhere over there, and where was it? So this is just a little geography lesson in case anyone needed it. Hopefully people can recognise what Africa looks like on a map. And then on the little eastern horn of Africa is relatively war-torn country that we know as Somalia. I refer to it in my title slide as the Somali Horn of Africa. And that's because the Somali people inhabit a reasonable portion of Ethiopia, Djibouti, and the country of Somalia, which is kind of split. It's probably politically contentious, but Somaliland in the north declared independence almost 25 years ago. They don't have any oil, so the world doesn't want to recognise them. But a lot safer than some of the areas in the south, although still quite war-torn. I've been working there on and off over the last 10 years, and working the majority of that time at University Hospital and the university there as well. So back in 2012, I think, I first went there. And I turned up in the hospital over there, and the local doctor said to me, "Can you do obstetrics?" And I said, "Yeah, I can do obstetrics." He said, "Good, you take that half of the hospital and I'll do this half of the hospital." So there are two of us for the hospital, which functions as close as it can be to a tertiary referral centre in a country that has no functioning health system. So I spent the first few days trying to work out which way was up. Noticed as I was doing my ward rounds an unusual phrase, and I'll sometimes say to the nursing staff, "Where's this lady's baby?" And they said, "Oh, that one didn't cry." And so after a couple of days I said to them, what do you mean that one didn't cry? And before I continue my story, I should have said before, I'm sorry, I realise this content is confronting for some people. I hope to bring it across in a way that there is hope, but if anyone wants to talk about stuff after, I'll get any time I'm happy to. Okay. So I said to the nursing staff, "Okay, what do we do if it doesn't cry? What do we do if the baby doesn't cry?" And they said, "Well, you wrap it up in a cloth and you give it to the grandmother and she will go and bury it." Okay. But do we do anything else first? And they looked at me and said, "Like what?" And it became apparent that nobody had ever taught anyone there about neonatal resuscitation. So a baby came out that didn't cry and it didn't breathe by itself. It didn't make it. We know that if all we do is help the baby take a few breaths, 70% of neonatal deaths are preventable. Okay. And they just did not know. That conversation led me to go back there with an NGO. One of the various different things we did. One of the things we did was a project which runs internationally. It's called Helping Babies Breathe. And it just teaches people very simple things. It has a very basic, reusable bag that you can help the baby breathe with. A very simple way to suction some mucus if you need to. And then teaches people the importance of keeping the baby warm, washing your hands, just very, very basic things. So as that started to roll out, one thing led to another. If you're going to start resuscitating babies, you're going to have some sick babies that need to be looked after. So there were, at the time, 10 years ago, no paediatricians in the country, and there was no neonatal unit in the country. We did find in the back of a donated shipping container a couple of incubators, and so we figured we better train some nurses in how to look after babies. And so it became a process of training. You know, one thing leads to another thing, leads to another thing. Over the last 10 years, we now have around 700 people that have been trained and are all over the country who can resuscitate a baby and help the baby transition to life outside the uterus, which is which is awesome. The other thing that people always use is babies under 37 weeks can't survive in Somalia. It's not possible. This was entrenched to the point where if somebody came in and there was evidence of distress in early labour at 36 weeks, they would not do a caesarean section because they said the baby can't live anymore. So it took time to change the culture, change those things, and we started talking to people about kangaroo care. Kangaroo care is just skin-to-skin care. Obviously, Australians, we know what kangaroos are. I don't know how some guy in India coined the term kangaroo care. I do know there is not a single person outside of Australia that actually understands what we're talking about when we talk about kangaroo care. And people were quite resistant to it. So we reached a point where we knew if we had a baby that was born and it weighed over about 900 grams, it had a reasonable chance of surviving as long as the mum would do kangaroo care, because people couldn't afford to stay in hospital. Okay, if you have a baby that weight here in Australia, it's in hospital for 6 months or more. Our discharge goal weight was 1,100 grams. Okay, so here you would be usually 2.2 kilos, or more. But there's no point keeping a baby in hospital if its presence there means that the family can't feed the rest of their kids because they've got no money for food. Mariam and her little boy Abdi were one of the first ones, and she was a lady who just wouldn't give up. All her family wanted her to give up, and it was quite frequent that we would have families come in and want to discharge their babies from the unit. And Mariam would come in the morning and say, my family are coming today, so I'm running away to hide, but I haven't abandoned Abdi, I will be back. Okay. And that was her thing for about 4 or 5 weeks. She would hide whenever her family came so that they wouldn't make her leave. He bucked the odds, and that was at his, I think, about a 3 or 4 month check. So she was one of the first ones who actually kind of understood kangaroo care. Somaliland at the moment is, they're saying it's the worst drought in 90 years. So there's famine and there's also civil war at the moment. Despite both of those things, it still remains that the most dangerous thing a Somaliland woman can do is get pregnant. If you are living in Somaliland, your risk of, as a woman, of dying from a childbirth-related cause in your lifetime is 30%. Okay? 30% risk, which is massive. And we know the things that affect that are not rocket science. Yes, you need to have good nutrition. Yes, you need to have access to a skilled birth attendant. You need some pretty basic sets of skills to make a difference with that. So in a country where those skills were lacking, we got involved very much in education. And the Somali people love to learn. They are generally good at remembering things and not great at practical things. So we have to reinforce things quite often. And a few years ago we put together a program which the Fistula Foundation ended up funding for us for doctors over there. So there wasn't, when I first went there was no graduate training at all. So we wanted just to provide basically a 12-month program that taught them how to do safe obstetrics, safe caesarean sections, but also how to look after sick babies because there's no paediatrician to handle sick babies. So we started working with that. When I go back, I still get involved in those things. So we've now, while I was over there last time, we trained the 49th doctor in obstetrics, graduated, which is lovely. And with the skills they've learned when they go to their regional areas, if they share those skills with the staff in the health facilities and communities where they are, We know that the set of schools they have will decrease neonatal morbidity and mortality by about 70%, and maternal morbidity and mortality by about 40%. That's harder to affect maternal morbidity and mortality because there's much more reasons that impact into it. So hopefully they've got a good skill set to get started with. With the nursing staff, this was a neonatal resuscitation session that we ran recently, and we were teaching them advanced neonatal resuscitation. When you're resuscitating newborn, it's different than when you're resuscitating kids that are a bit older. And so we know as health professionals we'll start doing chest compressions to help their heart beat if it's less than 60 beats per minute. Now, what we discovered is that these ladies who were midwives and nurses couldn't take a pulse. Right? Their education system, particularly the education system that women have, is such that they don't know how to count for 15 seconds and multiply by 4. So we ended up finding some songs that are at 60 beats per minute, changing the words, indoctrinating, getting people to do CPR at 120 beats per minute is easy because that's Baby Shark and that's the most annoying thing ever. Right, so we had to find an earworm that was 60 beats per minute as well. So then they know, okay, if it's slower than this, then you need to start doing chest compressions. So some of it's just finding different ways to do stuff and finding some creative solutions. All right. Hope some things are free, sharing the knowledge is free. Some things have a cost. This is Fatima holding a little girl. I met Fatima a few months ago. She's 41, and it was the 6th time she had been pregnant. She'd had several miscarriages, and in her previous pregnancy she'd gone into labour in a village. There was no birth attendant. After 3 days in labour, she was eventually brought to the city, and she had a little boy who was stillborn. So I met her when she was 38 weeks pregnant, and she didn't have enough fluid around the baby. She's 41. She doesn't get a lot of chances for pregnancy. So I said to her, look, we can induce labour, and there are some risks with that. It's very challenging to monitor labour closely over there. But if you want to, we can have a cesarean section. It's the safest way for you to get a healthy baby. And she talked with her family about that, and they really wanted that. But cesarean section costs about 6 months' wages. And Somaliland's in the middle of drought at the moment. So we quick phone call to some colleagues back in Australia, and they said, yep, let's do it. So she got her little girl and was absolutely beaming. We often in Australia think, stupid gap fee to see the dermatologist. You're sitting in my field of view. It's probably a stupid gap fee to see the GP as well, and certainly for the gastroenterologist and all these sorts of things. I am grateful that when we need an operation, whether it be for cancer, whether it be for life-saving, whatever else, we've got a public health system and people can get it. Sometimes we have to wait for elective stuff, and wait is frustrating, and it's frustrating for me as a doctor and for my patients as well. But it works. There is nothing in the world that is worse than the anguish on a mother's face when she has to choose between a life-saving operation and feeding a tube. But that's still the world over there. I was very fortunate this time around. Some of my colleagues, not long before I went, we'd been at an event and I was meant to pay someone back for something. I said, don't pay me back for it. Take the money and see what you can do with it. Just find something useful. So you have to be careful that we're not breeding just dependents. but there is genuine need in it as well. And I was talking with my colleagues last night and said, oh, just tell them what difference a little bit can make. All right, why not? So we had about 3,000 Australian dollars. Okay. For 3,000 Australian dollars, we paid for neurosurgery for 3 newborns. There's high rates of spina bifida and hydrocephalus over there because there's not enough follow. So we're very fortunate that the hospital are working over there. One of the local surgeons has been trained to put shunts in. So, so we sorted that. We gave baby a new bum. He was born without one, so he needed one. So he got a new bum. 6 cesarean sections. We had 12 antenats that couldn't afford ultrasounds that we saw them, a couple of CT scans. Someone needed an emergency appendectomy. Had half a dozen blood transfusions. 48 days of care in a neonatal intensive care unit, and paid for midwifery upskilling days for 45 weeks. It doesn't take a lot to do that. It doesn't take a lot. This is not about asking for money, just to say that, you know, I'm really privileged to be able to take a little bit and go, wow, it makes a difference. You know, it makes a big difference. Every one of those midwives, you know, and actually, the midwife training cost $120 for 45 people to be updated, and they all spent 2 days training. One was an update in WHO labour care, so safe labour management, and the other was on neonatal resuscitation. You know, it's, you know, $120 to do that. It's just phenomenal, and it will make a big difference for people. All right, I'm nearly done, I promise. This is Buba. Buba has 14 children. She had her first baby when she was 14, and she's now nearly 40. Their family are very poor and live near one of the areas where rubbish gets dumped. Her son, Cutter, washes cars. And I met Cutter because he used to come around and say, Dr. can I wash your car? Dr. can I wash your car? My car's filthy at the moment. I had a very clean car. The entire time I lived in Somalia. I came to understand that Cutter wasn't allowed home for the night unless he'd made a certain amount of money for washing cars. And that was because that's how the rest of his siblings were able to eat. So he would come, and sometimes it was quite late at night. Dr. Paula, can I wash your car? Yes, you can wash my car. And so he'd wash the car and maybe take some rice or some potatoes and up he'd go. He came around one night and said, Dr. Paula, I think my mum's pregnant again and she's sick. I said, okay, bring her in. And she was indeed pregnant with twins, and she had quite severe preeclampsia at 27 weeks. So she ended up having preterm twins and was in the hospital, and this was one of her kids. And she gave us this incredible gift, and that's what I want to talk to you guys about in 2 ticks. So when we come to maternal and child health care, we know that globally, across the globe, every 2 minutes there will be a woman die from pregnancy-related reason. Still, the women's health globally is appalling. 70% of those maternal deaths are going to be in sub-Saharan Africa. Somaliland and Somalia are number 3 when it comes to maternal deaths, I think, and the second worst in the world when it comes to neonatal deaths, with currently 1 in 10 not making it to 12 months of age. 1 in 10 kids don't get there. So we have to do everything that we can to try and help this kid survive. And we were harping on about kangaroo care, trying to explain it. And used to drive me absolutely nuts because people just wouldn't do it and they didn't get it and I couldn't explain it and whatever else. So we were trying to explain it to Uba, and one of the guys, Rhoda, was talking with her and she's translating for me, and then Uba looked at me and she looked at Rhoda and she said, and Rhoda said, ha, which was yes. And she went, ha, which was yes. Stop. What just happened there? What happened there? It was this like light switch had gone on. And what Uba had shared was a saying that her grandmother had told her. There is an old Somali proverb, and what that phrase means is the baby grows strong on the skin of its mother. Okay. And I said, okay, let's not talk about kangaroo care ever again. All right? Let's remind people that there is this awesome proverb, you know, in their history that just needs to be remembered. And I think, you know, this is something that's been my story over there, is that I often find that people who have nothing to give financially have an incredible richness that they can give in terms of knowledge and life and culture and all those sorts of things. So some colleagues here, some fellow GP obstetricians said, hey, it doesn't take much to make a big difference over there, does it? No. I said, do you reckon people would be open over there if we did a little thing here about giving hope instead of flowers? And I said, I suppose, is that what you want? And I said, well, it's really nice sometimes patients give us flowers, but we don't need them. You know, we reckon they'd be up for this. So we found a local designer to do us a little picture and put the Somali proverb on the bottom of it. This will come as no surprise to the majority of people in this room, but the male doctors over there are disorganised and useless and couldn't organise a thing. The women are organised, right? So there's actually no Somaliland Medical Association. There's no Somaliland GP Association or gastro or anything like that. Well, there aren't gastro people, but there are a couple of physicians there. But there's none of that. The only organisation that exists is the Female Medical Doctors Association. So we had a chat with them and said, what do you think? You know, to roll this out across the country, like to, you know, stick of these on every little, you know, on every little health clinic that exists, and you know, maybe a couple of bigger things as well. What do you reckon it would cost? If we could have $500, then we could go and we could do free clinics at the same time we put the posters up. Like by each clinic. No, total. Okay, let's do that. So we've left these Somaliland female medical doctors to get organised and remind people that there is hope in the heritage, you know, and it's not a matter of taking on board some weird Western concept, but just remember that this is something their grandmothers knew and we need to know. You know. We've got young midwives that are trained to go back out there, and there are, you know, there's always stories of heartache, but for the most part, there's hope, and that's what we have to rest with. You know, ultimately, as the sun goes down, we go, right, there's always some rubbish that happened in the day, but the sun will rise again tomorrow, and there's hope for tomorrow. And there's incredible hope for women in Somaliland, and it's a privilege to be part of it. It's also a privilege to come back here. That's all I've got to say. Thanks for listening.
Does anyone have any questions for Paula at all?
I just wondered, why Somaliland in the first place? How did you end up there?
Yeah, so when I was training at uni, I knew some refugees that came across from Somalia, and one of them was a doctor. He just used to talk about his country and whatever else. And he used to chat and say, one day you'll have to see what medicine's like in Somalia. And in all honesty, by 2011, I was totally fed up with medicine in Australia. I was sick of red tape. I was sick of everything from Centrelink to prescribing rules and all these other things. And I thought, I wonder if I still like medicine if it's just about medicine. I take all these other things out. So, I remember the discussions that I used to have with Hassan and with others, and thought, maybe now's the time to go. So I literally Googled hospitals in Somalia, found 2 email addresses, sent off this is who I am. I must have been better at doing bios back then. And offered them a few months at the end of the year if they were interested. One hospital went back, so I went. Discovered that the health situation there was so bad. It was really, really easy to make a very, very significant difference in people's lives. And I think most people in the health profession go into it at some level because we want to make a difference. And honestly, all I had to do over there to go home at the end of the day and know I made a difference was turn up to work. And so it was, I guess at a selfish level, it was very rewarding. It was hard. It was heartbreaking. It was certainly working at the sharp edges of a broken society. But it was obvious that a little bit of assistance could go a very, very long way. That's what I did. And now I just keep going back there because I'm like, I actually understand the chaos. I've got a relationship with people. I speak a little bit of language very badly. After 5 years of language, my friend said, Dr. Paula, now you speak like a 3-year-old. It means now when I go back, even if I only go back for a couple of months, I'm not spending time being a medical tourist. I can slot in and help out the rest of the people.
Thank you, Paula. That was an incredible insight to some of your work. I've spoken to you a few times over the years about some of your experiences and just in awe about what you've achieved over there and certainly have made an enormous difference, and it puts things into perspective for us back here, like you say, our healthcare system. I know we grizzle about it sometimes, but we are very blessed to have what we have here. So I'd really like to thank Paula for talking tonight. You've probably had no choice, really, to say you're coming tonight. I want people to hear the share your story, but I really, really do appreciate you coming in and spending the time with us. As with all the speakers, I know I've only got 2 left out of 4. We're dropping like flies, but no, I really appreciate it, and I really appreciate you all coming tonight. This was my idea and vision, that I had a room full of people listening to some fantastic talks, expertise that we don't generally get, and creating a conversation that may already be there but may not, getting you to talk more about these things going home, then to talk to other people, and then talking to your partners and children if it's appropriate age, and just getting that conversation happening. So hopefully I'll be doing 2 more this year, and they may be different topics, so feel free to come along to different towns. And then with a bit of luck, maybe continue it on to next year. So thank you all for coming. It's been a great night, I think, and drive safely. Thanks. This is a medical thing here, or I suppose other organisations, but there's a survey to do. I would really appreciate it. I actually forgot with the men last night. I think it would be helpful for me to show funding bodies, to say that it was worthwhile. It's only a couple of questions. I hate surveys myself. It's just if you liked it, if you thought that they were interesting, if you'd come to another one, and if there's any topics that you thought might be useful to talk about at other events, I'd really appreciate it. Thank you.